Good afternoon, everyone, and welcome to the final webinar in the Youth Transitions to Adult Care webinar series. Today, we're going to focus on sexual risk-taking in teenagers, solutions for the office. I am Morgan Gargiulo, and I will be your moderator for today's webinar. Next slide. So for those of you who don't know, I wanted to give a little bit of background on Qualidime. In January of this year, Maine Quality Counts merged with Qualidime, and we are a mission-driven national healthcare consulting organization with multiple offices across New England. We have over 35 years experience in improving healthcare delivery, and we specialize in quality improvement, project management, and technical assistance. We've been a leading federal quality improvement contractor since 1983 and are currently the Northern New England Practice Transformation Network since 2015. Next slide. So here's some relevant information about CMEs for today. Today's speaker has the following financial interest or other relationships. To mention, he's a lecturer for Merck on Nexplanon for long-acting contraceptive. CMEs will be available for participants who have signed into the live webinar. If there are multiple people on one computer, please make sure to put their names and email addresses into the chat box so we can include them in the attendance records. There are not separate nursing CEUs, but again, you can get a CME certificate. Once the webinar is ended by the host, us, you will get a pop-up on your screen that will immediately direct you to the survey. If you leave the meeting before we end it, that survey link will not pop up on your computer. So just make sure you wait for us to close the meeting. And we might go a little long today, so if you need to follow up with us after, Danielle's information is listed on the screen. And you will have 2 weeks to complete that evaluation. And again, if you have questions, please contact Danielle Ziller. Next slide. So a couple notes for today. All participants are in listen-only mode, and we ask that you use the Q&A function to ask questions or make comments. And just so you know, the video screen size and location of the boxes are all adjustable to suit your needs. You can mess with the different options at the bottom of your screen. Again, if you're joining by phone or sharing a computer, please make sure to get your information into the chat box. Obviously, if you're on the phone only, please send it to Danielle Ziller, dziller@qualidime.org. Next slide. So this webinar is funded through a contract with the Maine Department of Health and Human Services. So I will now pass it over to our speakers to get us started.
Great, thank you, Morgan. This is Jon Fanburg. This is the third part of a three-part webinar series on adolescent health. And the one today is sexual risk-taking in teenagers, solutions for the office, a red hot topic for y'all. So I'm Jon Fanburg. I'm a pediatrician. I'm also an adolescent medicine subspecialist. I've been in Maine for about 20 years seeing teenagers, young adults, and kids right up through age 27. I'm now director of the new division of adolescent young adult medicine at Maine Medical Center, where I see patients both for primary care and consultation. I'm going to let Brock and Brandy introduce themselves.
My name is Brock Libby, and I am an adolescent medicine provider here at Maine Medical Partners. I am originally from Maine, and I finished up my adolescent and young adult medicine fellowship back at the end of June at the Children's Hospital of Philadelphia, and I'm here sort of doing a lot of the same stuff that Dr. Fanburg is doing in terms of primary care and consultative work, but I also work in the gender clinic, so I work with a lot of transgender, gender variant youth.
Hi, my name's Brandy Brown. I'm a licensed clinical social worker. I've been working with and advocating for LGBTQ people for probably the better part of 20 years. And in the past few years, my clinical work has been primarily focused on working with transgender youth, running the gender clinic at Maine Med, and also the LGBTQ advocacy committee for NASW Maine, which I'm the current board president of. Really interested in a lot of different education and training opportunities for different people, and I'm thinking about shifting ways that we work with youth and LGBTQ people in Maine in particular.
Next slide, please. The one disclosure, I do lecture for Merck. It's not a financial disclosure, but we may be talking about Nexplanon today as well, so I need to throw it out there. Next slide, please. So we've broken this webinar into two parts. The first half is to be a presentation format where we're going to talk about sexual activity of teenagers, sexual risk-taking of teenagers, gender, and a little bit of history taking with teenagers. And then the second half, we've decided to do it through cases and bring out some hot topics along those lines, what we deal with on a day-to-day basis in the clinic. The objectives of this are to effectively screen for sexual risk-taking in adolescents and young adults, to empower teens in safe relationships, and to recognize gender as an important issue for this generation of adolescents and young adults. And before I pass it on to Brock, I just want to make sure that people at South Portland are aware they are on the camera as well.
That's why. That's why.
They can't be, but this really.
You're still on the camera.
Thank you, everyone. All right, are we ready for the next slide? Okay, so I'm going to take us through the beginning part of this presentation, and I'm really going to talk about heterosexual youth at the beginning, and I'm going to talk about sexual behaviors that we know and we have the best data for adolescent and young adult. But I think it's really important for us to talk about this thing that I've listed up here on the slide. I do think that many adolescents and young adults hear from adults that sex is very negative, and it's a very negative experience, and don't get an STI and don't get pregnant. And I just think that we want to really be thoughtful about that, because that's sort of setting people up to have a negative relationship with sex in general. So I do make sure to say to my teens that this is something you're supposed to enjoy, and if you don't, let's talk about it. So that's really what this first slide is about. Next slide, please. So this is really just looking at the breakdown of adolescents and young adults. So, and really sort of what it means for relationships to them, because there is a lot of cognitive development that occurs during adolescence. So in early adolescence, which is classically from 11 to 14, you know, relationships then are usually very short-lived, superficial, and they're usually arranged by an intermediary. By that I mean, oh, I have a friend, she's cute, do you want to meet him, like through somebody else. It's not usually someone taking the action to set up a relationship then. Middle adolescence, which is from 15 to 17, the interactions move then from a little bit more of a group situation to one-on-one. And of course, once you start spending time one-on-one with your romantic partner, that can become a venue for sexual activity. In late adolescence, so this is 18 to 21-year-olds, they're learning more adult-like emotional communication qualities, and so they're able to sort of say like, hey, you're sort of able to tell your partner, I really like you and I really enjoy you. And I think before that, it really just would feel pretty awkward. And I think the last part of late adolescence is really important as well. So conflict negotiation. So this is a part of screening with this age group for me, as I ask them about relationships and if they've had one, if there have been conflicts and how they've resolved them. And then young adulthood is 22 to 26-year-old. And so, I mean, they sort of really sort of keep going on this developmental trajectory we're seeing. So there's better communication, more in-depth communication, and also more comfort with sexuality, the actual action of doing it and discussing it with others. Can you not hear me, girl?
Can you speak up some, maybe closer to the mic?
Yeah, okay, I'm trying. Gosh, all right. For sexual behavior that we know of, this, I'm going to go through sort of the things that we know are occurring. So the first one is sexual abstinence. And so the majority of the data I'm going to talk about in these next few slides is from the Youth Risk Behavior Surveillance Survey. So this is really the best lens that we have into adolescence and young adulthood in the US. So this is a survey that's given to many people in high schools and early college, and they sort of identify what they do. So from this, we learned that about 45 and 48% of males and females practice abstinence, so about half of them do. There is this notion of primary and secondary abstinence. So I'm sure primary abstinence is someone who's never had sexual intercourse. Secondary abstinence is someone who had sexual intercourse, might have felt guilty about it, or might have felt differing emotions, but just decided that after that she or he wanted to wait an extended amount of time before reinitiation of sexual activity. So that's another just sort of breakdown of the abstinence and how many people are doing it. So the next part is solo masturbation. Now, this is nearly impossible to study. Just we ask about it, but it's something that's done solo, and it's something that people don't talk about a lot. So our best guess is that about 70% of males, and these are 15 to 17-year-olds, the majority of this data is looking at that group, and about 50% of males. I put up here asking your patients about this. For some people, this might feel shocking, but I do ask my patients about this and if they masturbate. I think it's important. It's a form of self-soothing, and especially for patients who have difficulties with anxiety, many of them will tell me I feel better by masturbation, which I think is just something for us to point out, and that's a positive thing. The next is partnered masturbation. So this is really just two people, boy and boy, girl, girl, girl and boy, who masturbate in the same venue together. And this is sort of really what we think of as preceding first vaginal sex and just getting a little bit more comfortable in that. And what we see, again, these things are really hard to measure, but what this found was that about 2/3 of males said they had, and only 10% of females said they've done it. So there's clearly some difference in reporting there, but this partner masturbation is just something that usually precedes the first vaginal sex. Next slide, please. So next is oral sex, and this is something that we do, again, have to be screening for. And so what we find is that about less than 1/5, so only about 20% of adolescents report giving or receiving. And when we look at over, but then when we move to above 18, we see that that number jumps up to 50%. So again, that's a practice that if we look at these data, it seems it happens to more later on in adolescent young adulthood. Vaginal sex is sort of what people sort of classically consider, oh, are you sexually active? This is what we're thinking about, again, through a very heterosexual lens. And what we found on this YRBSS is that 21% of males and 23% of females report a lifetime experience of this. But as we sort of move up through the 14 to 17 age group, we have increased reporting. So again, as they get older and have more comfort with sexuality, this increases. And then finally, the last one is penile anal sex. And this is about what I've heard from patients and anecdotally is that this is something that patients will do to preserve virginity. Now, there's just a lot of cultural stuff that goes into everything that we do. And this is something that I have heard, and I've seen 2 patients down in Philadelphia who were reporting this. But as you can see, the numbers are pretty low. 5% of adolescents with less than 2% having done it in the past 30 days. So it's a pretty rare occurrence that at least being reported to us, but still important to screen for it. Next slide, please. So these are the screening recommendations that I have to discuss sexual health and with heterosexual youth. Really, the first one is huge. All clinical visits can and should be used as opportunities to discuss sexual health. Just checking in to find out what's going on. It might seem odd, but if you know the patient well, it's just an important question to ask. Regular and complete sexual health assessments are necessary for both male and female AYA, so adolescent young adults, and what that means is just annually during their visits. Solo masturbation may emerge earlier than other partnered sexual behaviors, so asking about it shows that there is an emerging sexuality that's coming along. And then beginning in early adolescent, providers should really be assessing the AYA's close and intimate relationships. You gain a lot of knowledge if you ask them about their relationships and if they're enjoying it or if there have been any problems. And then I always, in my notes, I always make note of this. I don't write the partner's name, but just really important to write down partnerships and to be able to revisit those in subsequent visits. How's your relationship going that you told me about last time? Not only does that show an investment to the patient, but it also is your ability to check in to make sure that things are still going well there. Next slide, please. So I think that the first bullet is why I always ask about this. So the emotional content in a relationship can really let you know what's going on. So if you ask someone about a relationship and sort of how they respond to that question emotionally, will give you some good insight. And I will say, I frequently will ask follow-up questions to be like, oh, is everything okay? Or tell me why this seems so good. Sometimes I get shut down to be given more data, but I still ask about it because I think it's important. Next point is really if somebody tells you that they're abstinent, which is not a term that I've heard patients use, but if they say, oh no, I don't have sex, just make sure you really clarify and ask what that means, because frequently they're going to be talking about, if it's a female, they're going to be talking about penile vaginal sex. And then the other thing is, our culture's changing a lot. And so we always have to be aware of the presence of an FWB, which is friends with benefit, or a hookup relationship. So a relationship that's really casual and informal, but it's important to ask about these, even if an AYA is involved in another, what we on the outside would view as a stable relationship. To be asking about other sexual contacts is really important. And then, we know that adolescence is a very dynamic time. Tons of things change. And like I showed on previous slides, there is major cognitive development. But really what people go through in addition to their cognitive development can really change them and lead to significant growth throughout their adolescence. So just checking in about that, and also being cognizant of the fact that someone saying at the age of 14, I'm not going to have sex till I get married, that might change really quickly, even at 15 if they meet someone great. And then the last part is crucial. This is the most important part in my mind of adolescent medicine in general, is just to really encourage open, honest, and direct sexual communication between AYAs and their parents. I frequently think that there's a lot of, when we ask the parents to leave, there's a lot of, oh, they're talking about secrets, but really the most important thing that I say is that it's great if you can talk to your parents about this.
Brock, I think you locked up there.
He does look a little frozen.
Does look locked up.
Yeah.
You're going to jump ahead quite a few slides.
Wait, here he is.
Oh, there you are, Brock. We lost you at the beginning of the beginning of this slide.
Yeah, sorry about that. So now let's move on to LGB AYA, so lesbian, gay, and bisexual. So just some terms here really quickly. Sexual orientation really includes three major things: sexual identity. So do you identify as lesbian or gay? Sexual behavior, what are the actual behaviors that you do? And sexual attraction, so who are you attracted to? Gender identity, Brandy is going to touch upon, but it's really just sort of an innate sense of male versus female, male or female, and there's a spectrum there too. Homosexuality is defined as a non-pathological variant of human sexuality. And bisexuality is important for us to really focus on too, because these are people who are erotically attracted to both men and women. And it doesn't mean that they're promiscuous. It doesn't mean they're not in long-term relationships. It just means they're equally attracted. And if we look at LGB AYAs, the ones who have the poorest psychosocial outcomes are actually bisexual youth. So it's just important to be checking in with them about how they're doing. Next slide, please. So prevalence is tough, but really the best study that was done was this huge study done in Minnesota. It included a lot of people. I was pretty impressed with it. And what they found out, I think they polled something like 50,000 junior and high school students. And what they found is 1.1% of students identified as homosexual or bisexual, and they found the prevalence was 3.1% in females and 2.2% in males. Not a lot to make from those numbers, but just shows it's out there. The numbers here are a little bit low, but I generally say about 3 to 5 or 3 to 8% is what I think of. This is sort of the data. Next slide, please. So if there's one thing that everyone can take away from this talk, it is really the top bolded statement here. And this is just super important for everyone to know, is that lesbian, gay, bisexual, and this includes transgender youth, when they are born, they're not innately at any increased risk of anything. It is how society responds to and treats them that elevates their risk into certain different categories. And that environment can start at home. So we know if rejection happens early at home and we feel the rejection from society, that's a double-edged sword. But it's just really important for people to know that. When a gay boy is born, he doesn't have increased risk of HIV. It's from the stigma that occurs that he has that. But if we do look globally from a population-based standpoint, when we think about LGB health concerns, the ones that we see most often would be certain GU cancers, eating disorders, pregnancy and parenthood are difficult, IPV, intimate partner violence, runaway and homelessness is huge, school problems, substance use, suicide, HIV, and other STIs. Those are things we want to screen for, but also sort of realizing that at the baseline, they're not at increased risk of this. It's just due to the stigma that they face. Next slide, please. So what I've done here is just put up some points about counseling the LGB AYA. So the patient is in front of you, and I think it's just super important to create an open environment where these things can be discussed and really sort of, but the way that I do that is I just screen if it's a female, you know, I just ask if they are attracted to females or males, and I just ask both, and I don't act like one is more important than the other. Second bullet point's really important as well. Don't minimize what the adolescent is going through. Saying it's just a phase can be really, can have negative impacts on the youth because that assumption behind that statement is that phases end. Phases usually end quickly. So the message behind that can be, don't worry about this, this will pass, you won't have to worry about it later, which can be pretty damaging. And the last, the third one here, if we talk to an AYA about homosexuality, it's not going to make them gay. It's not going to make them a lesbian. It just doesn't change who they are. It just provides a platform for them to discuss it. And then also just assure AYA that this is a normal variant. It's very common, and that sexual orientation is biologically driven, because that can sometimes make them feel a little bit better in the moment there. Next slide, please. So the top one, again, we just can't expect AYAs to define their sexual orientation prematurely. We don't need to put them into a box. We can ask them if they have a sexual identity, knowing that that can be dynamic and change. Conversion therapy is bad. It causes significant negative outcomes. We don't really want to be discussing that at all. And regardless of if the patient is LGB identified, we want to work on prevention of STIs and prevention of pregnancies. And then the last point too, this is huge, not all sexual minority youth experience difficulties with their orientation. So not all of them have a difficult time. The ones that are accepted at home and accepted in society do the best, but not all of them have poor outcomes. Next slide, please. And so this is an important part too, is talking to a parent. So if you're able to discuss it and have the time to talk to a parent alone, this is a concerned parent of an LGB youth. So I think that just really talking to them about how they're feeling and letting them know that they are not responsible for this. This is just who their child is. Make sure to offer correct, unbiased information on being LGB identified. And when a child gets upset, not everything is about them being gay or lesbian. It's just part of life. And most people who know me know that I do this often, but challenging society's stance that homosexuality is bad, just really challenging that and knowing who you are and what you bring to the table, not what society expects of you. And then exploring religious beliefs. This can be a really hard one, but we don't want to alienate our patients and sort of be like, oh, well, you're religious, so you're obviously going to reject your kid. There are usually lots of subsets of little pockets in these religious denominations that have affirming and accepting communities, just trying to find them. And then the last point, discussing HIV prevention. This is huge. So HIV really, I think for a lot of people still think of it as a disease between gay men. And so just talking about the HIV prevention is the same if your son has sex with another man versus if he has sex with a woman, and just really sort of talking about that and being frank about it. But also saying being gay does not mean you're going to get HIV. Next slide, please. And this is for Brandy.
So I think a lot of the things I would have to say when we think about gender really dovetail on the things that Brock was sharing about LGB youth, but often we lump LGBT together and we forget about the T. So I think that it's really important to really think about what is transgender, what is this gender identity, how do we support these youth in the primary care setting or other clinical settings. So transgender, gender nonconforming youth, I'm using TGNC as a acronym. There's many terms. That's something to get comfortable with. There'll be a lot of words you might not know that your patients might use, so being comfortable with different shifting language. But essentially, gender identity is an aspect. It's really internal. So someone's gender identity is their understanding of who they are in terms of male or female or both or neither. And sex, when I talk about sex, I'm considering sex as it's assigned at birth. So that would be sex that was ascribed to someone based on generally a cursory view of genitalia at the time of birth or from an ultrasound. And so it's really important to consider those as separate. For many people, they're the same. So those folks would be cisgender if their gender and sex are the same. And for folks whose gender and sex are different, we would use the umbrella term transgender. And then non-binary people, sometimes NB, sometimes genderqueer people would fall in this category of where their gender identity falls outside of a binary male-female box. So there are many people, up to a third of people who identify as transgender would say their gender is non-binary. So thinking about these words as large catch-all buckets or umbrellas is really helpful. So just another sex term to be aware of is illegal sex, may be different from gender identity or sex assigned at birth. So for example, in Maine, I could go down to the BMV today, sign a form and change my gender marker to MF or X. It would take about however long the line is, but once I got through the line, maybe 10 minutes. So I think it's really important for us to recognize that there's a sex assigned at birth. It may be different than what's presented on a legal document, and that there's a gender identity that someone has. And really asking those questions and getting comfortable and figuring out what are you using those questions for is really helpful. I think we're going to see an increased population of youth who are going to start communicating with providers about being transgender, genderqueer. And so in Maine, in 2017, the Maine Youth Integrated Health Survey, 2017 is the first time we asked about gender. So we don't have previous data, and the 2019 data is being released hopefully in the next couple of weeks. So we haven't seen the preliminary reports from that. But at that point, 1.5% of Maine high school youth said they identify as transgender. 1.6% are questioning their gender but do not identify as cisgender. So that's around 3% of youth who are transgender, gender questioning here in Maine. And then compare that to 15% of youth on that same survey who identified as lesbian, gay, or bisexual. I think we have a very large population of youth who are starting to talk more and be more open in sharing about gender identity and sexual orientation, which lends to the need for more affirming care, and that we need to provide affirming and supportive care. So next slide. So what is this affirming care anyhow? And that's really at any level. So we need affirming therapy, we need affirming primary care. And I would argue that any primary care doctor could become affirming. I don't think it's a something that you need to, at a basic level, I think we all ought to be affirming. And if you want to engage with youth, you need to use their names and pronouns, for example, that they give you. And I think that's a piece that's a huge barrier for a lot of youth, is if their doctor doesn't remember who they are when they say I'm a man or I'm a boy, and the doctor keeps calling them she, or saying things that relate to, that are gendered in a way that youth does not describe themselves, that is a way of telling the youth, I don't see you, I'm not safe to talk to, I'm not going to be able to help you. And it creates this barrier of discomfort. So I think what we need to do is think about how we're approaching youth. Are we using open-ended questions? Is it clear that we're avoiding assumptions? Do we explain why we're asking questions? Why are we asking about sexual partners? Why are we asking about behaviors? And I think being really open that you're asking about a risk, and you can explain that and articulate why you would ask a question about body parts. A lot of transgender youth or adults get questioned about things that aren't relevant to the visit. And so in a primary care setting, when you're assessing someone, you really do have an opportunity to ask a lot of questions, but we want to make sure that the patient understands the relevance of those questions, because they're often asked lots and lots of questions that are somewhat invasive in other settings. So also important to think about the language that the patient uses and the language that you use. So a patient might use different words for body parts. Someone might say something, they might say front hole instead of vagina, and if you're not comfortable with using that term, you want to at least avoid the word vagina for that patient who's really uncomfortable with that word. And when someone's really uncomfortable, it becomes more than just discomfort, but really increases their dysphoria and would create another barrier for them to be able to communicate with you about their body parts and about how their body, bleeding versus menstrual cycle. Those are just a couple that come up. So it's important to pay attention to what your patient's words are, and are you using gendered words when your patient's not comfortable with those. I think it's really important when we think about sexual activity and risk that we're asking about parts and partners and behavior, and that we're not making assumptions about who those partners are and what parts the partners have. Transgender people are not necessarily going to tell you the body parts of all of their partners, and they aren't necessarily going to say, oh, I'm dating a transgender man. They're going to say, I'm dating this guy, his name's Joe. He's really awkward, but he, paints really well, and I like him. So they're not going to say, oh, I'm dating this person, and this is their body, these are their body parts. Or they might say, I'm dating a non-binary person, or they might just use different pronouns. So be thoughtful on what is the intention of your questions. Are you asking about sexual partners? What kind of sex are you having? What body parts are involved? And being comfortable not making assumptions based on the initial language that someone uses to assess risk. Next slide. One of the biggest barriers, one of the number one questions I get asked as I go about talking with folks in the community is, can you tell me who a safe, affirming primary care doctor is going to be? The second question would be, who's a safe therapist I can work with? And I think that shows we have to figure out how to make it obvious that we're safe and that we are comfortable with gender. People feel that they can't share this with their doctors. Up to a quarter of transgender people don't ever share with their providers their gender identity. They don't feel that is going to be safe. They're afraid of being outed sometimes, youth. They think, oh, if I tell my doctor, then they're going to tell my parents. And so making sure that they understand it's confidential. Or they think, I might tell my doctor and they're going to keep it safe, but I don't want the nurse who checks me in to know because she's on the PTA with my mom. Or I don't want all of my doctors to know this is just a private conversation. I'm just thinking about it. And I think that's really important to consider, where people are in terms of being out if they are sharing things. A lot of transgender people, especially youth, are very uncomfortable with their body. They have a lot of dysphoria, and so they may have a lot of discomfort with physical exams. And so being mindful of that, there may be times where a physical exam needs to be deferred to another appointment. Be thoughtful of what level of physical exam can this person manage and what's going to help them feel ready and more comfortable. Sometimes it's helpful to let people get ready for a physical exam, mentally, physically, however that looks for them. There's a whole history of mistrust within the medical system. There's a narrative in the community, which you could access very easily online, a whole narrative about how the medical system is against transgender people. And so, and that narrative is very true for a lot of people, and I think we have the opportunity with youth to shift that narrative so that people can feel that they can trust their providers and that their providers are going to help them. Another thing, transgender youth, they don't understand the risks. I'm sure a lot of adolescents don't understand the risks, but there's a challenge with understanding that the risks do apply to them. I think there's sometimes a little bit of not quite magical thinking, but it's an adolescent thinking, but to another degree sometimes, where people forget that their body parts put them at different risks than how they see themselves. And so someone who a transgender young man, for example, may just assume he couldn't be pregnant because he's a man, and men don't get pregnant. And so there's sometimes barriers around how people think about themselves. I think about myself as someone who couldn't get pregnant, therefore I can't. And I think helping people navigate those conversations is really, really very helpful. So that's the end of my 3 slides here.
So we're entering the second half. So the first part, we talked a little bit about some information lecture style format. Now we want to talk through some cases. And I feel like this is the real life that you guys are being faced with. This is your punchline, which hopefully you take away from the cases. One is the concept of screening for sexually transmitted infections is really important. Understand how to assess a teenager for birth control and offering it. 3 is empowering teens, young adults to have safe relationships and avoid rape or unhealthy relationships, and helping teens, young adults recognize and feel comfortable with their own sexual identity and their interests. Have the next slide, please. So the first case, a 15-year-old heterosexual cisgender female comes to your office because she has initiated sexual activity. My questions are fourfold for the 3 of us. One is, what do I mean by the term heterosexual cisgender female? What questions would you ask? What screening is recommended? And how would this change if it were a 15-year-old homosexual cisgender male? So we want to tackle one or all those?
I can start.
You start with the first one. What do I mean by the term heterosexual cisgender female?
Yeah, so we sort of talked about this at the beginning, but a heterosexual, so she self-identifies as someone who has sexual attraction, sexual behaviors with other cisgender males. And so cisgender is the term that Brandy covered, or the opposite of the term that Brandy discussed. So transgender is gender and sex assigned at birth differ. And in cisgender, they're the same. So sex at birth and gender identity are the same.
I might suggest that this 15-year-old is probably going to say they're straight.
Yeah.
Probably not going to use the word heterosexual.
Yes.
So, and I think we shouldn't assume that their partners are cisgender. So that's a question that comes up sometimes, and especially youth, and how they define themselves. So this heterosexual cisgender female may have, we don't know who they've initiated sex with. We can assume that it's probably a male identified person, but we don't know all of their body parts and who they are.
And I'm going to throw in there, I'm going to ask them what do you mean by the term sex? Because it differs by different people in different ways. And if they can't put it in words, sometimes I'll give them choices. Does it mean touching, kissing? Does it mean penis goes inside vagina? Does it mean oral sex where penis in the mouth, or vaginal to mouth? And I'll get comfortable with the words. And that's something that was hard to get used to in the beginning. I had to practice the words before I was comfortable in front of a teenager. Some teenagers cringe at some of the words and are not less comfortable, and some are more comfortable with it. And letting them know it's safe to talk about anything in my exam room.
Yeah, I often will acknowledge that it's awkward to talk about things. If you're having sex, you should be able to talk about sex. If you think you're going to have sex, you should be able to talk about having sex. So trying to acknowledge that it's awkward, but also that if you're doing things, you should feel comfortable talking about them.
What are you screening this patient for?
Well, so for me, the screening that I would do, and I would discuss it with her, would be the CDC recommendations for STI screening in adolescence and young adulthood. So what we know is that starting with sexual initiation, it's recommended annual to have a urine GC chlamydia screen that's done. So I would recommend that to her. But I try to be really thoughtful in my language, because again, I don't want the story to be, oh, I had sex, great, let's screen you for an STI. Like, I just make sure to say, this is sort of part of your sexual health now that you have gone through sexual initiation. And so I do discuss that. If she's only had sex with one person and I was screening her in Maine, I wouldn't draw an HIV and look for syphilis. I would sort of do it risk-based. So I would start with a urine screening, and if anything was positive on the urine screen, then I would do a blood draw for HIV, syphilis, and Hep C. But that would be the screening that I would do in terms of STIs. There would be a lot of other screening questions I would ask her, but that's what I would do for STIs.
I guess my other screening piece, I'd ask, does she worry about getting pregnant? And is there any form of contraception being used presently? Is it adequate? And what should we start if it isn't? How would it change? Sorry, go ahead, Brandy.
No, I thought you were done.
How would it change if there's a 15-year-old homosexual cisgender male?
So for me, the one thing that would change is, again, I would again discuss STI risk. I would be pretty frank about the fact that there are different risk categories in sexual behaviors that put us at different risks. And we know that the number one way to acquire HIV is from receptive anal sex with homosexual cisgender males. We know that is the number one way to do it. And so I would just be really frank about that. I would discuss that. I would talk about protection. And I would also briefly discuss, depending on the risk level of this patient, I would talk about PrEP, which is pre-exposure prophylaxis, which is just very briefly is a pill that we can give to patients who are at high risk. They take it once a day, and it really reduces their risk of HIV acquisition to nearly zero. It's really, really successful. And just talking to them about that as it's another tool in their tool belt to have increased safety.
Let's move on to the next question. Case number 2. A 21-year-old heterosexual cisgender female comes to your office and states she is in a relationship with a 22-year-old heterosexual cisgender male. What questions would you want to ask? How would your counseling change if she had any stigma of intimate partner violence? And how would this change if the male partner were at the appointment with her? Brandy, you want to tackle one of these, or?
I think going back from the last one and this one, I just want to point out, so my screening as a social worker is a little different than medical screening, but I always ask about consent. And I think this ties into intimate partner violence. I'm thinking about, how did someone obtain consent and how do they feel about consent? And so I ask people their relationships, when they're in relationships, I ask them if does their partner respect them. I ask them, how does their partner, how does consent work, and what does the communication look like between them when they want to have, when they're intimate or not intimate. So just making sure people know that they always have choices. Just because you're in a relationship doesn't mean you're obligated to anything. So I explore those things.
I think colleges have become really good with this the first week of school, setting kids up for really strong communication if they're getting into relationships, and having communication right up front as far as what they want to do and what the rules are and what they aren't. If they want to have sex, that they're very explicit. Do you want to have sex verbally, and what that means? And that's important. So it decreases misunderstandings and decreases people going farther than they intended to go.
I think if the both of them were in the appointment together, I think I would still have those conversations. And I like to emphasize when I talk about consent that the goal is enthusiastic consent and not just compliance. So communicating about how enthusiastic do you feel about these encounters is a good conversation starter.
Yeah, I mean, the first question that I ask when someone tells me that they're in a relationship is, I'm like, oh, do you like the person that you're in a relationship with? And I really get some pretty shocking looks, but I think it's just really important to talk about and just to be like, what are the good parts of that partner and why are you with him or her? Just to highlight that all relationships are somewhat different. And I will say that in terms of the third point there, that's a really dicey situation. I personally never had a situation like this, but I did when I was in Philadelphia. I had a 19-year-old female come to me for Depo, and her boyfriend was with her the whole time, and it was really weird in the room, and I was like, what's going on here? The boyfriend went to the bathroom, and the girl looked at me and said, he can't know that I'm on Depo, and if he finds out, he's going to leave me. So that was like the closest I came to this, and then he comes back in the room. So it was a really hard and tricky situation to deal with. And how do you talk about DEPO, and how do you talk about sort of the elephant in the room almost when you're trying to skate around it? And so in that instance, I was able to rely on the social support that I had there. We had an IPV social worker, and I also reached out to our social worker there because I couldn't talk to her about it in that moment, which was really hard and really challenging. Made me feel a little bit defeated because she was also like, you can't call me because he might see the number and he might answer. So the stuff is really tricky, but I rely on my supports that I have around me in terms of social workers and just people who are much more facile at dealing with this.
We got one question from our audience. Any insights on how to get society and politicians in particular to be more affirming? Who should be leading this discussion?
I think all of us should. I think we should all be having this discussion. I think the medical community has a responsibility to recognize historical trauma, really, that we've created as just institutionally, but not supporting people for many, many years. So I think we should be leading that with some ownership and some, we have accurate knowledge now and data and information. I think people in the community, we need to figure out how to partner and not have so much us versus them. And so we need to figure out how to build partnerships and coalitions and build each other up, which means we actually need to see each other. So I think if you don't know transgender people, for example, in real life that aren't your patients, then maybe that's something to think about. Why not? Why don't I know anyone? Where would I, they're not, people aren't, hiding. So it's just interesting if you realize that there's no one in your life that you encounter. So thinking about not just advocating on behalf of your patients, but advocating as a person who sees people in your community, whether it's the grocery store or your church or wherever, I think helps us all move forward with changing society, politics, etc.
And so I think one thing that's happened as we've moved along on gender is there's a fear of saying the wrong thing in the office and making things worse among physicians. Mm-hmm. And to some extent, Brandy's taught me, just ask the patient, what name do you want to be called by? What identifiers do you want to have? And let them lead the process, even to the point where if I have check boxes I can put in my computer, showing the patient what the screens look like and say, which check boxes should I check or not check in your chart? And let them take control of what I should know, and that helps me along the lines. It also helps the more I get more lectures and conferences on this topic, I get more familiar and comfortable with it as well.
Mm-hmm. I also just want to say about the political stuff, I do address it with my patients, and I do ask them about it. And I read this really fascinating paper a while ago that basically showed that when gay marriage became legal, that psychosocial outcomes and quality of life improved for LGB identified people because they had that institutional support that Brandy mentioned was institutional discrimination in the past. And so our youth that are going through this stuff feel these negative effects from the current political environment. And it's just important to touch base on that. You don't, just to be a sounding board, I think is very meaningful. And to also just point out that this is here, this is tough, but we're going to keep moving forward because you're still an awesome individual. But it's hard.
Cap case number 3, please. 14-year-old cisgender male comes to you and discloses that he may be gay. Any follow-up questions? How's this change if he has initiated sexual activity with someone that he met on social media application?
So the first thing that I would...
Oh, Brock, you locked up. Brandy, you want to handle it?
Sure. I mean, I start off with, how do you feel about that? And, what does that mean? How do you feel about being gay? What do you know about being gay? What does it mean? Does that mean you're starting to have, feelings of attraction? Does that mean you don't fit into a box that you thought you fit into? So I just want to explore it in an excited way with people if they feel like it's exciting, but some people also feel like they don't want to be gay and that it's a bad thing. And so want to explore, what does it really mean to you and where you're coming from?
Along with that, I would add that I sense out who that they've disclosed information to, how are they received, because how one is received might have more impact on their mental health than anything else. Did their parents accept whatever they told them? Did their friends accept them for who they were?
Yeah, I think that's what I was gonna say. Sorry, before I got cut out again, but I always ask about social supports. Who has been told, who they can turn to, who they know that they can discuss this with. And I think the follow-up, the last point is important. So if a 14-year-old cisgender male is having sex with somebody he met on a social media app, the first thought is that this might have been an anonymous encounter, and it just elevates the risk. So it's just continuing to discuss PrEP and continuing to discuss safe social practices. But we just know that the more, anonymous sex is definitely much more increased risk. Anytime that there's any element of deviance added to it, like hiding the sex from other people, you increase the risk. So I do always ask my youth, even though sometimes I don't love the answer, but I do ask how they met their partner, because I think it's important.
I also care if they're meeting people on social media with low threshold, are they having lots of partners? And there's a subset of people who have many, many partners, and I start talking about what's the criteria before you have sex with somebody. I don't care what your criteria is, but at least you have some, and then ask the next person that comes along, does that person match your criteria? So they're a little bit selective in the process. Let's go on to the last of our 4 cases. 17-year-old trans masculine adolescent shares about a recent sexual encounter he had with an older woman, age not disclosed. He shares this is the first time he has had sex and appears very uncomfortable. He's been on testosterone for about a year. So my questions are, do you ask about consent? Could there be a risk for pregnancy? How to ask about what kind of sex, what body parts were involved, and do you assume that the older person is cisgender? Do you think the patient would automatically tell you if she wasn't? I'm going to throw one other question to lead off with. Define transmasculine adolescent.
So I think that's a good question. People might not say I'm a trans man. They might say themselves as transmasculine, so towards the masculine side of an identity, but might not necessarily identify as male. Maybe they do. Most likely assigned female at birth, but lends towards a more masculine, transgender masculine presentation and identity. And so I think it's just a good reminder. Kids aren't going to come and use those words that we want them to use, like heterosexual, cisgender. They're not going to use those words.
Yeah, I think this is a great case. I think that for me, I see quite a few trans youth on the whole spectrum. And so for me, when I ask about sexual risk for them, I really remove all gender. So I just ask them, what I would say to this person is, did this human have a penis or a vagina that you had this interaction with? I sort of just try to take all gender out of it to get sort of the data that I need to determine the risk. And so that's really the question. And that's how I modify the questions with patients that are on the trans spectrum. And I would not assume that the older woman is cisgender, and that's sort of how I would get around that. So, did this person have I don't really care truthfully what her gender identity is, just what body parts does she have and what were used.
I do worry about age gaps, and we don't specify in this case how old the person is. But when there's significant age gap, as Brock knows, we were talking about yesterday with a real patient, I worry about levels of maturity and levels of experiences. And is there a power relationship here where the older person's taking advantage of a situation or controlling a situation? And then the big next question is, what do you do about it? Let's say there's a 5 or 7 or 8 year age gap between the 17-year-old and the next person up 25 to 30. It's not reportable per se, but I'm not sure it's a healthy relationship either. One's ready for marriage and one's ready for holding hands and kissing. So how to address that is a hard topic, but it's something that one should address.
And also just one last thing about here, because so it says on there he has been on testosterone for about a year. So I know that was put in there for a reason, so I just want to address that part. So really, when you put someone on gender-affirming hormones such as testosterone, after about 6 months, the patient becomes amenorrheic, so that means they don't have any periods. However, testosterone is not a reliable form of pregnancy prevention. So we know it does not reliably inhibit ovulation. So these patients can still ovulate even though they're amenorrheic, and there thus is a pregnancy risk. So in the majority, again, I'm sort of, this is a generalized term, but in the majority of adult trans people that I have met in a clinical setting, the majority of them have either Nexplanons or IUDs. They have long-acting reversible contraception in place to offset that risk.
That same Brock, I've had some people who refuse the contraception because it's not part of their identity, and that's a concern.
Mm-hmm. Yeah, I think, Brenda, I think that that's important to discuss. I think that if you're talking to a trans, if you're talking to a trans male and you're talking about contraception, they really don't love the idea of a combined oral contraceptive because they know combined oral contraceptive has estradiol in it. And it's important to talk about, one, the amount of control of bleeding you get with the estradiol. And I also talk about ethinyl estradiol versus endogenous estradiol and how it's very different. But some of them will simply say they don't want it, and I just have to honor that with the knowledge that I won't be able to control bleeding the best without ethinyl estradiol on board.
Yeah, I think it's important to find out what kind of sex someone's having and who they're having sex with, but because I think often people get kind of shepherded into, oh, you're probably going to have sex and we want to prevent pregnancy because that would be a bad thing, without realizing that they might not be having sex with partners who would get them pregnant. And so I think breaking down those assumptions, because I think most of those young men who feel that the contraception would be against their identity also would feel that getting pregnant would be even more dysphoric. For young people, many people intend to get pregnant and go off of testosterone to do that, but for young people in general, that is not their intention. So exploring with them their feelings around how would they handle that if they did become pregnant, I think might make them a little more open to considering preventing that.
Any other comments with this case?
I think we have one more question, John, maybe.
Question here, would sex with a 17-year-old be reportable in case number 4 if there was an age gap? This is tough, okay, question, because our state laws need some revision. What is defined by rape is one definition in our state laws. What is reportable is a different definition in our state laws. And so our state laws, as I understand them, are very limited. And what's reportable is if somebody is having, somebody is 14 or 15 years of age, having sex with somebody who's 5 years older, not 4, not 6, not 10 years older, that's reportable. So that means a 14-year-old with a 19-year-old and a 15-year-old with a 20-year-old. And then there's also little carve-outs if the older person is a teacher or law enforcement or something like that as well. That's it. And that's the issue which comes up. So I think the best judge I would say on what's reportable, if it's in an unhealthy relationship, that might be reportable. And beyond that, I'm going to leave it to the lawyers. Do you have another comment on that, Brandy, from knowing the state laws? Or?
No, I think that's accurate. I don't think it would be reportable in this case, but worth exploring boundaries and consent and how they met someone and who are the people they talk to when they're worried about safety.
And our other question is, are there links which explain the LGBTQ acronym and how one may identify?
I think as far as links for further education, I would say there's a LGBTQ Health Education Network through Fenway Health, and they have lots and lots of webinars and resources that really there's no reason to replicate what they've already done. Free webinars, and they're pre-recorded resources that I would go there first.
And one last comment that came on is, but state by state laws are different, so recognize that. So some situations are reportable in some states and not in others. But
that's true.
We are at the top of the hour. We finished on time amazingly for the amount of stuff we covered. We thank you for participating in this snowy day, and hopefully there was enough transmission and connection to hear most of what we had to say. I'm going to pass back to Danielle and Morgan. Thank you all for participating with us today.
Thank you.
Thank you so much. I know we went over most of the questions, but if you have any additional ones, you can put them in chat or in the Q&A, and we'll make sure to get some answers from our experts here. So Danielle, if we can go to the next slide. Oh, looks like that's cited stuff. So I know we're out of time, but we wanted to mention that we just launched a Child Health Clinician Resource Center. The link is on the screen. We're also going to put it in the chat. This is a free tool that you can register for. If you want to go to the next slide, Danielle. The Resource Center includes helpful information for clinicians and community providers around various child health topics, such as adolescent transitions of medical care, adverse childhood experiences, and developmental screening resources. There are also links to some external resources as well as webinar recordings. You can see right now we have loaded the previous two from this webinar series. And we'll be continually maintaining this resource and adding additional items. So be sure to check back in. We're actually in the process of adding a new section on ADHD that we'll hopefully have up soon. So please take some time and register. We'd love to hear your feedback. If you have any items you're looking for that we don't have, please let us know and we will work to get that information for you. Next slide. Again, here's our contact information. If you have any questions regarding the CME credits, you can reach out to Danielle. We did have, just folks really enjoyed the case scenario. So that's actually excellent feedback. So thank you very much. And next slide, we are on social media. So be sure to follow Qualidime for the latest tools, resources, tips, and upcoming events. So thank you to all of our presenters. We will go ahead and close this so the evaluation can pop up for everyone. And we look forward to working with you guys again.
Thank you, everyone.
Bye, thank you.